Lucy, for inviting me to join you tonight. It's a pleasure and a privilege. So since we're short on time, I'm just going to cut straight to the point. So since the first version of the GOLD guidelines in the early 19s, their successive updates have shown a substantial change in the approach to the COPD patient, from one led basically by the grade of obstruction to a more multidimensional perspective, which also considers symptoms and history of exacerbation. In 2012, the HESAPOC guidelines were published, and it was the first time in international literature that a more different approach to COPD was proposed, based on clinical phenotypes. This year, both guidelines came to light, and despite their difference being the main one, their approach to treatment, they both aim at a more personalized management of the patient with COPD. So in the next two slides, we'll see a brief summary of the differences between both of the guidelines. They're very small and not very significant regarding the definition. In the new GOLD version, the term inflammation has been removed from the definition, maybe with the purpose of reducing the role of the inhaled steroids from the treatment. And also tobacco has been left out as the main cause of COPD, considering a wider range of harmful particulates and gases. When approaching the patient with a smoking history, HESAPOC considers or proposes that a spirometry be performed to all of those with a history of smoking greater than 10 packs a year, while GOLD raises the bar to 20. And the first difference that we come across is when we look at the risk assessment. So when we talk about risk in COPD, the term comprehends not only the risk of exacerbations, but also the risk of disease progression, of future complications, of a greater use of healthcare resources, and of a higher mortality risk. Therefore, risk is not only predictive of mortality, but will also be predictive of a greater diagnostic and therapeutic interventions. So if we can see here, whilst GOLD uses symptoms and exacerbations to grade risk, HESAPOC also incorporates the post-bronchodilator FEV1, so the grade of obstruction. Another basic difference is the classification of the patients according to phenotypes. To simplify the treatment approach, the present version of HESAPOC proposes determining phenotypes only in high-risk patients, while GOLD doesn't even consider phenotypes at all. On the treatment of on the chapter of treatment of stable COPD, again, we will come across several differences, being the most significant one, as we will see later, the use of inhaled steroids. So moving on to the risk assessment. According to the history of exacerbations, the dyspnea score, and the post-bronchodilator FEV1, we can divide patients, according to HESAPOC, in low-risk and high-risk patients. So while low-risk patients must fulfill all criteria, it's just enough to comply with one to be a high-risk patient. Low-risk patients will be those with a mild to moderate obstruction, with a dyspnea score according to the Medical Research Council's scale of 0 to 2, and with a history of exacerbations on the past year of none or one that didn't require hospital admission. If we look at GOLD's view, it varies slightly. So whilst in the 2011 version, GOLD introduced the ABC schema, adding symptoms and history of exacerbations to the evaluation and the treatment of the COPD patient, previously based just on FEV1. It's precisely the FEV1 that has been removed from the risk assessment at the present version. So now the grade of obstruction is important in the diagnosis and in the prognosis on the patient, but it's not used to guide the therapy. When we look at the history of exacerbations, GOLD uses the same cutoff as HESAPOC, of 2 exacerbations, or 1 leading to hospital admission. But then the dyspnea score, GOLD uses not only the Medical Research Council scale, but also the COPD assessment tool to grade the symptoms. Another main difference between HESAPOC and GOLD, as I previously mentioned, is the difference in the division of the high-risk patient in clinical phenotypes. And the importance of this lies in the fact that these phenotypes will direct the choice of therapy, aiming therefore at a more personalized treatment, symptom-based and modulated by the severity of the disease. HESEPOC therefore distinguishes not only between those patients who exacerbate and those who do not, but also between those with the clinical features of emphysema, chronic bronchitis, or those with asthma symptoms known as asthma COPD overlap or ACOS phenotype. And it's precisely this ACOS phenotype that probably is the most notorious difference between HESEPOC and GOLD. Because despite the fact that up to 20% of patients with COPD also have asthma, and that these patients have a distinct response to therapy, surprising enough, GOLD still hasn't incorporated the concept. And in fact, it barely mentions it. And it hasn't been until the last version that it mentioned eosinophilic inflammation as a possible biomarker that might predict response to inhaled steroids has been added. So this mixed phenotype is characterized by chronic obstruction that is not completely reversible, with symptoms suggestive of asthma and with a very positive response to bronchodilators, a very positive bronchodilator test, as well as an eosinophilic count of over 300 cells. And we know that these patients have eosinophilic inflammation both at stable disease and during exacerbations, and that they have a high risk of exacerbations, and therefore are candidates for inhaled steroids as a first-line therapy associated with long-acting beta agonist. As we know that in this patient, the inhaled steroids reduces the frequency of exacerbations. So with all of these in mind, we move on to the treatment of stable COPD. With the treatment, we aim to improve the symptoms, reduce the frequency and the severity of the exacerbations, and to improve the prognosis of the patients. And as we can see here, the treatment in the latest version of HESEPOC has been simplified by dividing patients into high risk and low risk. And on the other hand, the treatment schema by GOLD is a bit more complicated. But I do have to say that despite the complication, it does propose not only a model for the initiation of treatment, of the pharmacological management of the COPD, but it also suggests a subsequent escalation or decalation of the treatment according to the individualized assessment of symptoms and exacerbation. So regardless of the complexity, it is a more dynamic approach compared to the previous versions. So for low-risk patients in HESEPOC, bronchodilators are the main treatment. Proposing LAMA as a first-line treatment to which LABA can be added, since LAMAs have shown a greater capacity to prevent exacerbations. In high-risk patients, double bronchodilation is the initiation therapy for all of them. Since we know that it's preferred to single therapy because it improves dyspnea, it improves quality of life and the need for rescue medication. In those patients who do not exacerbate, theophylline can be added, but these can only be used as third-line therapy, never in monotherapy. Exacerbators will be then treated with double bronchodilation, but if they continue to exacerbate despite proper therapy, inhaled steroids should be added because we know that they have a greater preventive effect, and more so in those patients that have a high eosinophilic blood count. The reluctance to use inhaled steroids in COPD comes mainly from the risk of pneumonia related to them. And funny enough, it seems to be higher in those patients with a low eosinophilic count. In exacerbators, additional treatment with mucolytic and theophylline can be added, and antibiotic treatment with macrolides can be considered for those who have more than 3 exacerbations a year. In exacerbators with chronic bronchitis and severe obstruction who continue to exacerbate despite adequate treatment, roflumilast or PDE4 inhibitor can also be added because we know it reduces the exacerbations in these patients. And importantly, the ACOS phenotype patients, as we have said, have a distinct therapeutic approach in which the combination therapy with inhaled steroids and long-acting beta agonists is the first-line treatment to which LAMA can be added. GOLD's approach is a bit different, as we said. Groups A and B will be treated only with bronchodilators. Inhaled steroids have no place here. And since in Group A, GOLD proposes that we use any kind of bronchodilation, even short or long-acting bronchodilators. The difference to HES-EPOC, where really short-acting bronchodilators have no use or not used as a maintenance therapy, but only as rescue medication. So difference to HES-EPOC also here. They propose using long-acting muscarinic or beta agonist, and the choice be made by the symptoms, by the patient's perception of the control, the symptom control with the medication. So Group C, whilst GOLD doesn't propose LAMA over LABA, in Group C it does propose LABA since it has shown to prevent exacerbations better than long-acting beta agonist. And when symptoms are not controlled or exacerbations, double bronchodilation can be used. Inhaled steroids are not preferred in these patients unless they have asthma symptoms. But again, GOLD is very reluctant to use inhaled steroids because of the risk of pneumonia. It's only in Group D that the combination therapy with double bronchodilation is recommended as a startup treatment, as an initiation treatment. And again, it's preferred to combination with LABA and inhaled steroids. In some patients with history or symptoms suggestive of asthma, initial therapy with inhaled steroids can be considered. And in the present version, GOLD does mention that an elevated eosinophilic count could be used to select the patients that might benefit from inhaled steroids. But then again, it does say that it's still in debate. GOLD, interestingly, also proposes that when no clinical benefit is shown from adding on inhaled steroids, that this treatment should be stopped, or you consider stopping the treatment. So, to round it all up, we can summarize that the prime differences between the guidelines are regarding the risk assessment, the distinction between clinical phenotypes, and the recognition of the ACOS phenotype, all of which are the elements that will guide the choice of pharmacological treatment. But regardless of their differences, both HES-EPOC and GOLD propose an individualized treatment that is dynamic and that aims to reduce exacerbations, improve symptoms, and improve the prognosis of the COPD patient. Thank you very much.
Thank you very much, Alicia. The next lecture is Dr. Mark Cohen, and he will talk about an exciting topic, which is biologic treatment in asthma. The next stop to a personalized treatment. Dr. Mark, please share your screen and start your lecture. Thank you.
Well, good afternoon here in this side of the Atlantic, and good night over in the other side. We'll be talking about biologics in asthma, especially in severe asthma, that we know that around 5 to 14% of the 3 million asthmatics globally will have severe asthma. That will give us around 15 to 42 million people with severe asthma. And we need to make sure that we have a definition of severe asthma, and ATS and ERS since 2014 has given us the definition, and it has barely changed, and it is an asthmatic that remains uncontrolled, and he should be referred by the specialist. This specialist will phenotype by the inflammatory process, and the biomarkers that we have are evaluating if there's an allergy sensitization, and also if there's presence of high eosinophil, high IgE, high exhaled nitric oxide. That will give us two phenotypes, the T2 inflammation with high EOs or high FeNO, and the non-T2 inflammation. If you still have doubts, if this patient has a T2 inflammation in referred centers, they do induce sputum, and depending if there is presence of sputum or not presence of sputum or eosinophils in sputum, we divide in four phenotypes. The T2 inflammation, the mix that has both eos and neutrophils, polygranulocytic, which will give us low eos and low neutrophils, and the neutrophilic, which only has high neutrophils. So why do we use biologics in asthma? We know that the majority of the randomized controlled trials say that 75% of patients are controlled on LABA and ICS. But the real world registries really show that less than 40% of the patients are well controlled, and it's even less probably in this severe asthmatic group. There's also the concern that we talked about of the long-term side effects of the high-dose inhaled and systemic steroids, and we have had proof already that biologics in asthma have been studied in patients remaining symptomatic despite aggressive treatment and demonstrating that they are efficacy and safety using biologics. So nowadays we do what we call the FeNO or endotype guided therapy according to the selected biomarkers, but we have to remember, and it's very important to keep in mind, and that the patients continue taking their baseline medications on top of their biologics. We know a lot about inflammation pathways, and we have learned to find targeting markers or biomarkers to give treatments, and we have multiple mediators downstream and upstream depending on these newly easily to find biomarkers. And we also have now a lot of biologics that are directly targeted to these biomarkers. Some are subcutaneous, some are IV, some are oral, but these are still on studying. This is what we have approved: omalizumab, mepolizumab, rislizumab, and FDA just approved this Tuesday benralizumab. Omalizumab will be used in the allergic high IgE asthmatic, and we can use it in greater than 6-year-olds, and it has shown a reduction in exacerbations in around 50% of the patients. And we have also seen that with this reduction of exacerbations, there's a reduction of steroids. It's also showing improved quality of life, and they have an improved response if they have a high eosinophil count greater than 300 or a high FeNO. Mepolizumab, ralizumab, and benralizumab is for the eosinophilic asthmatics, and they have also shown a reduction in exacerbations and, of course, reduction of systemic steroids and improvement in pulmonary function. They all respond well in those patients that have a high eosinophil peripheral count, especially those that have a very high, greater than 500. Dupilumab, it has been used in patients that don't need to be eosinophilic, but they do have increased symptoms of asthma and uncontrolled exacerbations, and that has also shown a reduction in 60 to 80% in exacerbations and improved pulmonary function, and of course reduction of systemic steroids. This is in the N rail of accreditation by FDA and EU. So how do I personalize the treatment of severe asthma? First, the most common and what we have the most is the T2 inflammation phenotype. That is divided in allergic and non-allergic, and the allergic phenotype is those that have clinical symptoms of allergies, a high IgE, skin prick test that's positive, and specific IgE. They can be with or without eosinophilia. If they have allergy without eosinophilia, omalizumab is the treatment of choice. If they aren't controlled, we should use alternatives or oral corticosteroids. If they do have eosinophilia, we look at the IgE level to see the dose, and we see that we can use omalizumab once again. If after 3 months they're not controlled, we can switch to mepolizumab, and if they're not controlled after 3 months, we should switch to rislizumab. In the IgE low with eosinophilia and allergic asthma, we can use either omalizumab or anti-leukotriene 5 inhibitors. And then we have the non-allergic asthmatic with eosinophilia. We start with mepolizumab in those patients. If they're not controlled, we look at the IgE. If they have a IgE greater than 30, we recommend omalizumab. If it's controlled, we continue, but if they're not uncontrolled, we go to reslizumab. Those patients that have a low IgE, we go directly to reslizumab. And then the ones that we lack a lot of evidence is the non-eosinophilic phenotype. We have the mixed eosinophilic phenotype. We give a trial of macrolides, especially azithromycin, 250 milligrams 3 times a week. And if they respond, we continue. The studies go to 1 year, but we probably need to continue. If there is no response after 3 to 6 months of therapy with azithromycin, we go to the T2 biologics. The polygranulocytic phenotype, we need to reassess the differential diagnosis and be very active in the non-pharmacologic treatment and also usage of non-biologics, which would probably be the best used bronchothermoplasty. The neutrophilic responds much better to tiotropium, macrolide therapy, and also if they don't respond to these, we go to bronchothermoplasty. Who has a better response? We need to find good biomarkers. The only ones that we have right now that show us a better response is those that have a Th2 inflammation biomarker with high eosinophils, especially greater than 500, those with nasal polyposis and high FeNO, and those patients that have a high history of exacerbations. We need to have a follow-up in these patients. Most of them will respond even in a month with a decrease in eosinophils with the new IL-5 biologics, but at least every 2 to 3 months, we need to assess symptoms to see if we're having a decrease in sleep and daily life symptoms and decrease in steroid intake. And for the patients that have nasal polyps, see if the taste and smell has returned. Then looking at biomarkers, looking at drop in eosinophils and FeNO, seeing if there's improvement in lung function, decrease in exacerbation, and improvement in quality of life. How safe are these? We have here the 4 Cochrane reviews on all 4 of the present biologics. All are very similar to placebo, and these are the tables of decontinuation because of severe adverse effects, and we see that there is no difference between this and placebo. So they are safe. So in conclusion, severe asthma is not a rare disease, and it has significant consequences. And now we have a better understanding of the pathophysiology of asthma, allowing us to do endotype-guided therapy. We are a step closer to personalized medicine for these patients, and we know that we can decrease exacerbations, systemic steroid use, and healthcare resources. We can improve their asthma control, pulmonary function, and quality of life, and we know that they have really minimal safety concerns. And the future, why this is a very exciting and new era, I think, for precision medicine and asthma. We need to discover and understand the new pathways that may be modified with these new target-specific biologics, know when we can use, but even better, when we shouldn't be using this because we may do harm and we should make concern about the high cost. Other future considerations is duration of therapy, how long should we use, and can they be weaned off? Can we use it in earlier disease stages? And despite this high cost of biologics, can it solve the problem of poor medication adherence that we have with our classical therapy right now? Because this is direct observed therapy. And as we have been seeing, biologics are being used in other pathologies, especially in obstructive diseases and COPD. We're starting to learn a little bit more about this. Thank you very much, and hopefully we'll have some questions later. Thank you.
Okay, start whatever you want. Well, thank you for your invitation. I apologize for not being able to present in English, and therefore I'm going to speak Spanish, and I think that Pablo has hired a couple of interpreters. Well, in these 30 minutes I'm going to try to see the incidence of COPD exacerbation, what happens with mixed viral bacterial co-infection, what about optimization, antibiotic therapy, respiratory failure, non-invasive ventilation use, and I'm going to draw some exclusions from the point of view of the intensivists, because it is a special group of patients. It's clear then that the detection of viruses in COPD exacerbation is highly variable, between 22 and 64%, depending on when the sample is taken and the type of presentation, whether if it's acute or moderate, etc. And depending also on the season of the year, the time of the year. We see here picornavirus and coronavirus, metapneumovirus. Picornavirus and metapneumovirus are the most frequent ones. Then we have also coronavirus, parainfluenza 1-2-3 virus, RSV, and influenza A/B virus. There is a seasonal pattern that is significant. We see the exacerbation increases in winter, but we see that it is maintained all throughout the year with an acceptable frequency. And in this recently published study, we see the prevalence over time, and we see that this type of exacerbation decreases over the years. But there is an important etiology of patients coming to the UCI, and 70% of eCOPD are caused by respiratory infection. Bacteria, virus, or atypical. Bacteria 40-60%, virus 30%, atypical 5-10%. And depending on the acuteness or severeness, we can expect to find some certain types of germs. In our database of patients with flu in Spain, these are the main microorganisms that we've been able to isolate in those patients with flu. And if we see different from COPD patients and non-COPD patients, we see that pneumococcus is the main, pneumoniae is the main bacterial or species, then Aspergillus, and this is due to the high incidence between flu and fever, and then is influenza aeruginosa and pseudomonas. But we have a very important problem, which is that in the treatment of such patients, when they are admitted to ICU, they have antiviral and antibacterial infection. We have that sputum prolens, can be a sign for infection in COPD exacerbation, but this is not always like this, because in some cases these they can have microscopically a significant sputum, and the sputum characteristics are not a useful marker to differentiate viral and bacterial infection. The interesting thing here is the almost 3,000 patients that we included in the Spanish database. Out of this, only 16% were having bacterial co-infection, so 482 patients. But all of them received antibiotics, wide-spectrum antibiotics, that can develop resistances, such as the prednisolone and the third-generation prednisolone. And this is why we wanted to see whether we could find in these patients some patient's profile that could not have to receive antibiotic treatment. And through an automized analysis, we were able to see that the variable that was more related in these patients with a bacterial co-infection was procalcitonin, with some important cutting points. And we wanted to demonstrate that there was a group of patients that were could have up to 1.1 calcitonin, but if they did not have hemodynamic alteration, you can see that the incidence of infection is less than 7%, and possibly these patients should not receive antibiotics in the onset, or they could be assessed for an empirical treatment, an early empirical treatment. On the other hand, we have the fact that the use of non-invasive positive pressure ventilation has a good response by COPD patients because this treatment reduces mortality and the treatment failure, and it improves pH and PaCO2 rapidly. However, non-invasive ventilation in acute respiratory failure, the evidence of use should be cautious because there could be a high severe community with acute pneumonia. Then we were concerned about the fact whether we were using too much non-invasive ventilation, because there are some risk factors, and we saw 56.8% of patients were presenting failure, NIV failure. When we again applied an automatic score to see what variable was most associated to this failure, we saw that the SOFA cutoff 5 was related to this. We could differ between two types of patients, one with SOFA less than 5, when they have COPD, and when we use positive ventilation, the success rate is very high, and when they do not have COPD, the success rate is much lower. But in case of patients that have a SOFA of 5 or over 5 and they don't have COPD, the benefit of this treatment maybe is not too much. I mean, NIV success is only 21.4% with 2 quadrants in filters, and we consider that this is a piece of data to be borne in mind. What happens with the subgroup of patients, COPD patients, that were ventilated with viral pneumonia? We have ventilated 476 patients. 44% were having an invasive mechanical ventilation, and 55% were having an NIV. The mortality rate in the first group was 31.2% in ICU. And when we see the multivariables, only shock was a variable independently associated with NIV failure in the multivariate analysis. And we tried a new automatic analysis, and we see that again the logistical regression is fundamental here, because this will indicate whether to use NIV. We see the NIV failure 32.1% in the first node compared to 15% in the second node. To conclude with, and to give room for discussion, we say that respiratory infection is common in the COPD patients. Antibiotics are given regularly to these patients. However, we see an overuse of antibiotics in very frequent cases, and patients through biomarker should be more carefully evaluated. The level of organic dysfunction, the SOFA score, seems to limit the beneficial effect of non-invasive ventilation, mechanical ventilation in COPD patients with viral pneumonia, and the presence of shock was a variable independently associated with NIV failure in COPD patients with viral pneumonia. Finally, COPD patients with SOFA over 5 or with shock have a higher risk of NIV failure and therefore should be closely monitored to avoid delays, intubation delays that could lead to higher mortality rates. Thank you very much, and I am at your disposal in case you want to ask any questions. Gracias, Alejandro. Bien. Supongo que ahora vamos a dar paso a las preguntas. Así que...
Good afternoon. Yes, I have a question for Dr. Mark Cohen.
Yes?
What is the role of bronchial thermoplasty in asthma? Is only for the neutrophilic phenotype, or we can use it in whatever phenotype?
Good question. Right now, only on the neutrophilic and the polygranulocytic phenotype for right now, especially with new biologics like we just saw in the presentation. We don't need to go with the thermoplasty. The trials, really, we only have 3 trials with thermoplasty, so very little evidence still to really confirm the efficacy and also the security of doing thermobronchoplasty in these patients, but I would recommend using in the non-eosinophilic asthmatics since we don't have very much to offer them.
And I have another question. Do you think there are any role to use a biologic therapy for COPD patients? For example, overlap COPD asthma patients?
Definitely, yes. Even we're having those trials running right now in eosinophilic COPD, if you want to call it ACO or whatever you want to call it. I think there will be a role for that eosinophilic COPD patient, but I think we need to wait for the trials to show us security and efficacy compared to what we have right now in treatment.
Thank you very much. I don't have any question.
Hi, Mark, one quick question. What do you do when the biologic therapy fail? How do you continue?
Okay. Usually you should be seeing a response by around a month or 2. If you, they say 16 weeks, okay? If you don't see any improvement, some say, let's try it a little bit more. Really, if you don't have the biomarkers and they haven't gone down, they probably need to be switched to a different biologic, depending on the algorithm that I kind of try to review quickly because it's such a short time. But I think you should give them around 2 months to 3 months the most. And if it's not responding, you should switch to an alternative if you have the phenotype with high EOs or high IgE.